speak the initial aspects of the meeting. Please go ahead, Prerna.
Good evening, everyone. I'm Dr. Prerna, Secretary Gyne Oncology and Preventive Oncology Committee. On behalf of KASOGA and our committee, I welcome all of you to the webinar today. Today's topic is genetics and genomics in gyne cancers, the contemporary must know. So we are currently witnessing a paradigm shift where one-size-fits-all treatment is being replaced by precision medicine. So understanding the genetic blueprint of gynecological cancers is no longer a luxury, but it is a must-know for every practicing clinician. Hence today's topic. I warmly welcome all of you. Special welcome to our patrons, Dr. Hiremat sir and Dr. Nagraj sir, our President, Dr. Durgadas sir, our Secretary General, Dr. Shobha Gudi ma'am, our Honorable Treasurer, Dr. Shobha Bengalgi ma'am, and Dr. Soumya Mani ma'am from EC Member Southwest Zone to the webinar. I also welcome today's speakers, Dr. Darshana Patil ma'am, Dr. Kiran sir, and Dr. Rupesh sir to the webinar. Finally, warm welcome to all our audience who have logged in for the session today. Welcome one and all. To invoke the spirit of wisdom and clarity, let us begin with a virtual lamp lighting and prayer, symbolizing the light of knowledge that we aim to spread through this deliberations of today's webinar. Over to Mr. Arun for the same.
Kurutvang kalyanam arogyam dhanasampada shubham kurutvang kalyanam arogyam dhanasampada shatru buddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvang kalyanam आरोग्यं धनसम्पदा शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा.
Thank you, Mr. Arun. Now I request Dr. Rupesh sir to speak a few words and address the session.
Yeah, thank you, Dr. Prerna, for the initial inputs. I would like to welcome Rajshri Paladi madam also, who is the upcoming president of KASOGA. Welcome, madam.
Thank you.
Yeah, we have had quite a long, time. I mean, it's been quite a long time that we actually had an academic session for gynecological cancers. But I was always intrigued about the importance of genomics, because as an individual gynec oncologist practicing, I keep coming across the same old gynecological cancers which are like conventionally managed, but there are a plethora of changes that have taken place over the last few years when it comes to how, as Dr. Prerna said, the precision medicine has been kind of changing the paradigm of the cancer care when it comes, apart from the conventional chemotherapy or surgery and all that. So that is when I thought that this is something which all of us in KASOGA, the gynecologists, should be knowing about. I'm sure like many of you know about various aspects. So initially, that's the reason I thought like the first talk especially would be for the mainly concerned for the general gynecologist in your clinics. When you get your patients, you take a complete detailed history taking. So but what about the role of the genetic history? So that is one part. And with regards to endometrial cancer, wherein the molecular oncology has taken a huge leap. So that is one arena wherein I wanted another speaker to speak about it, another expert. So that is where Dr. Kiran will be speaking. And yeah, the third capsule will be wherein like in ovarian cancer, how things have changed. So yeah, these were all the important aspects that I feel that every gynecologist should know, and hence this webinar. So welcome once again to everybody who have logged in. So over to Dr. Darshana. I would like Dr. Shobha Gudi madam to speak a few words on this, madam, if madam is there, and also followed by Dr. Rajshri madam. I mean, your thoughts on this webinar before we actually start.
Hello everyone, good evening. Has Dr. Durgadas Asrana not joined? Arun, any news from him?
Madam, sir is little bit busy.
Yeah, I think sir had told he'll be busy, madam.
Okay. So I'm happy that the Preventive Onco Committee is doing a webinar on this subject, because I think This is very relevant to the general gynecologist also. And there is a lot of knowledge gap as to the interplay of genetics and cancer risk is concerned. And very often we do not know what to ask for and in which patient what test would be more useful, because many times the tests are out of reach for the patient because they're expensive as well. So this is not a new subject for either FOXY or KASOGA or BSOG, but I must say that doing it in a clinical setting as it is being done today will really give better understanding of the subject. So I congratulate the committee, Rupesh and Prerna. And since Dr. Durgadas is not there, I invite Dr. Rajeshri Pallati, the president-elect, to say a few words, and then you can continue with your webinar. All the very best.
Thank you, ma'am. Thank you.
Thank you, Dr. Shobha and Rupesh. Good evening, everybody. At the outset, I must congratulate for taking up this relevant topic, because preventive gynecology is what we are looking for in this era wherein cancer has become so prevalent now. Every second, third person in a household would be suffering from one or the other kind of cancer because of the various factors which are influencing the life today. And our role as a responsible gynecologist would be to screen out the families and the patients who are affected by such cancers, and then to give the best of the advice to take measures to prevent such thing from happening. Also, I would like to congratulate Rupesh for winning a prize in the Foxy Delhi recently, and for his outstanding performance.
Thank you.
And it's nice and wonderful to see that the youth of Karnataka, who would be the future leaders, are taking good strides in the field and representing Kasoga at all levels, at the national level, at every level, be it academia or be it the talent promotion and all. I met Rashmi and Rupesh in the conference in AICOG, and we really had wonderful exposure to all the academia and all the friendship and the fellowship which followed. Congratulate Rupesh and the committee for taking this relevant topic. I'm sorry to note that there are hardly any viewers, maybe for the amount of webinars which are following, but this is such a high content and valuable information that we are going to share today. But definitely it is going to help a lot of people in their outlook towards the cancer patients. And it doesn't necessarily mean that there are maternal mortalities occurring, but yes, there are also equivalent high number of patients whom we are losing to cancers, the breast and the uh, cervix and ovaries and such, and the gynecological malignancies. Congratulate you, and I think if we can record this and have the YouTube link, it will be a valuable learning material for many who have not logged in today. Thank you, and wishing you all the very best. Thank you, Dr. Shobha.
Yeah,
Thank you
if
so
I
much.
can take it forward from where Rajeshri, as my next president under whom I should function for Kasoga, I would just like to
We are
add
all
here.
together, Shobha. Please don't mention that under
Of
or
course,
over
of
is
course, of
is
course.
just a
But you are the president, I
nomenclature.
am the
We are all
secretary.
together.
Yes, yes, we are shoulder to shoulder, of course.
Yes.
And my duty is to support always. And this venture also, I support Dr. Rupesh, but you would have had a better response if you had declared this
Yes.
program a couple of days earlier. And if
Can be earmark. I would have a
yeah,
suggestion that can be marked on the calendar few days for such
yeah,
for such webinars. And I'm looking forward to have a calendar of events which will float it from April, so that I would request the committee heads herein, whoever are present, to just formulate the program, so that when we make it as a event, we can have a wider circulation and request all the societies
yes,
to circulate, because this is such an important information
correct,
which we are getting it in our doorstep. And
correct.
definitely those who are interested, at least those who are into the active gynec practice,
I'm
or
sure this is a
the
subject of
screening,
to
interest to
everybody.
many,
Yeah,
because every
it's a
household
subject of
nowadays has
interest to
some or the other
everybody.
kind of cancers prevalent. So I would request the committee chairs and Rupesh and Prerna and everybody who is here to have a plan of action as to what you're going to do for the consecutive year of 2026 till 2027 March, and give me a tentative chart or the calendar of all the programs which will be covering the entire aspect of gynecological plethora, so that we'll have it a more effective and impactful. I really feel sorry because 13 participants, of which 7 or 8 of us are the office bearers and the speakers and such. So let us have a wider reach out program, and we'll definitely share this YouTube link and make a statement in the groups, the WhatsApp groups, that this is a value-based edition that they shouldn't be missing. I think this is my
Sure,
suggestion.
madam. Thank you for the input, ma'am. I will
Yes,
definitely
yes.
consider to
Yes.
Please make your program
incorporate.
early and
Sure,
float
ma'am.
it well so that everybody is aware of it.
Yes,
Because
ma'am.
why
Sure.
you
Good luck.
must particularly know is the traffic in WhatsApp
Mm.
is very huge. And
Fine, that's fine.
every second there is a new message for people to
Yes.
read.
Yes.
Unless you are
So,
there
Shobha, madam, I
foremost in
have a
their
suggestion
brains,
here.
they will
If I
not
may,
join. Yeah.
I think
Yes.
we'll make a WhatsApp group specifically for the webinar, which will be hosted in Kasoga, so that if people log into that group of webinars, what we are going to have, then I think the pickup rate will be better.
Hopefully, ma'am. Definitely, ma'am. I'll
With
consider
the
all
calendar.
the
Yeah.
inputs, ma'am, from the
Yeah.
seniors. Definitely,
Yeah.
ma'am. Next time, I will. Actually, this time also I had made it. Only thing is that I was not sure of the dates finally, so because of which I maybe procrastinated. But definitely, shortly I will.
No,
Like
not
for
that. I
next
do
program, I'll
understand
do
that
it,
we
ma'am.
all were busy with the AICOG and we had so many things
Yeah.
coming up and all these things. It's not that, but what is of concern to me is that how many hours of preparation goes for the speaker and for the planners to put
True,
this
ma'am.
program together.
True, ma'am. True, ma'am. It
Yeah.
is. We will.
All the
I
best.
will.
Yeah, we'll do that.
Thank you, ma'am. Thank you so much.
Thank
Thank you
you.
so much.
Thank you.
Over to Dr. Darshana. Dr. Darshana,
Yes.
are you there?
Yes.
Yeah.
Yes,
So Dr.
I'm here.
Darshana Patel is a trained pathologist and who has been herself into molecular oncology. I would like Dr. Prerna to please read out her profile, please. Dr. Prerna.
Yes, sir. Our first speaker, Dr. Darshana, is a powerhouse of knowledge in the domain of genetic cancers, especially in gynecology. Madam's work spans in over 40 countries apart from the India and United Kingdom. With over 13 years of international experience and national experience, Madam is perfectly placed to simplify the transition from traditional history taking to modern genetic risk assessment. Over to ma'am. We are eager to learn how to interpret these results in our everyday practice.
So thank you for the kind introduction, and thank you, Dr. Rupesh, for extending the invite today. And I will just begin the first presentation, which is on the hereditary risk assessment. I hope my screen is visible to all.
Yes, ma'am.
Yeah, it is.
And it is, yeah, okay. So so essentially today we have gathered here to really understand about the genetic risk assessment that we could do as a gynecologist in the clinic. And of course, some of the slides that I may present may appear very, what I would say, may remind us of our first year of biochemistry. Plus, still, I will request to please bear with me, essentially because the first topic as well as the third topic are mainly so heavy in the terminology related to molecular. I really wanted to refresh our memory from the biochemistry. So let's begin. So essentially, when we are talking about all these genetic assessment, whether it's the hereditary risk assessment or when we will talk about the targets that which have come based on the DNA analysis, essentially what we are as a molecular lab analyzing is the DNA. So at this DNA, as we all know that we humans share 99.9% of our DNA. It's only 0.1% that differs. And even in that 0.1%, these are the normal polymorphism, as in we all are made up of these various trillions of nucleotides A, T, C, G, and each gene, each chromosome essentially would be, and essentially at the end the DNA would be built by these nucleotides. And this sequence is more or less common in 99.9% of the genome across humans. Only 0.1% may have some different genetic codes. So for example, here, as you can see, that there is a replacement of a particular nucleotide with another nucleotide C. And does that mean that this leads to a mutation? No, it is a polymorphism that differentiates maybe someone having light eyes with someone having black pupils. So this normal variation in the genome is called as the polymorphism. It just makes us look different from each other or have different personality traits and various attributes to our physical variation in our attributes. However, if at a particular location this particular change in a nucleotide at a single location, which we'll refer to as single base pair mutation, may lead to a complete derangement of the protein that is coded by that particular region of the DNA, leading to disease. For example, sickle cell anemia is caused by just single nucleotide change at one particular location, leading to such severe hemolytic anemia. And there are various such nucleotide changes that may appear. Like, for example, in this case, I have highlighted that few nucleotides have changed, then it will cause disease. If the nucleotides which have been deleted are relatively larger in number, we may have disease like, for example, DMD. Of course, the location at the particular gene, the particular area of the gene, which we refer to as in molecular terminology as codons, this is going to impact, will determine the disease that is being caused. Sometimes there are additional nucleotides which might be inserted, and we call them as insertion mutations, like in Huntington disease. So essentially, this is just to highlight that these are the so minor variations in the DNA that essentially can impact a protein which is very much necessary for healthy functioning of a particular cell type. And once that is deranged, that can lead to disease causation. Now, these genetic variations that we are really discussing today are of two kinds. One is the germline mutations or germline changes in the DNA. By germline, we mean that they are inherited. As a gynecologist, you already are doing the NIPT analysis and various other hereditary testings as well. So you will be quite well versed. Still, so these are the inherited mutations passed on from parents to the child. They are the disease causation will be determined by the location of the DNA which is affected, and as well as they will have variable penetrance. Some gene mutations, even though pathogenic, because they are autosomal recessive, may not necessarily lead to disease causation in the carrier person. However, if the same gene change is inherited in autosomal dominant fashion, then can lead to a particular genetic disease or genetic syndrome. Whereas the second part of the session today, which I will be speaking about, would mainly pertain to the somatic changes or acquired changes, the changes which are acquired by a particular cell in a particular organ, wherein that mutation leads to uncontrolled proliferation and thus the cancer initiation. And these such changes which are not present in other normal cells but are carried only by the cancer cells are called somatic changes, and they're of course not hereditary, and they can be caused by multiple factors. Essentially, the repair pathways being deranged, which otherwise should have been effective and corrected this genetic variation, being deranged, leading to this particular cancer initiation. So the first talk will be focusing about the inherited diseases, and the second talk we will talk about the somatic alterations, creating opportunities for better management or personalized therapies in today's world. So essentially, why when we are talking about the inherited mutation, it is being relevant at multiple stages. And if we have to really particularly talk about from the obstetrics or gynecology perspective, one definitely is the carrier testing. When a particular family history is there, the individual may be carrier of that genetic variation and thus may be predisposed to a particular hereditary disorder. It might also be relevant in the prenatal testing that you routinely opt for, like, of course, the last but not the least, where the development is not as fast paced as ideally, because this pre-implantation genetic testing has tremendous value in really selecting, of course, the ethical consideration is not today's topic, but to really have offsprings, even if there are severe inherited disorders in the family, the pre-implantation genetics can really help us to have a healthy offspring. So these are the various utilities of the inherited or hereditary germline testing that could be undertaken. For today's topic, of course, we are just focusing on one part of it, which is the carrier testing, which can help us to identify the risk predisposition to various cancers. So when we are discussing about the risk predisposition for cancer, usually it is just thought or perceived as a job to be done by an oncologist or a job to be done by a genetic counselor. But the gap that arises is majority of these individuals are not really going to seek an oncologist consultation, or majority of these carrier patients are really not aware that they should really get a genetic counseling because of XYZ factors which are seen in their family history. And as the kind of first caregiver or the first clinical contact, the gynecologist can definitely identify the high risk flags and kind of triage these patients in better manner to the relevant person. So we are not expecting that the genetic risk assessment that is happening in your OPD should consume all the time of your consultation. You are busy clinicians, but definitely you could triage these patients, alert them that, okay, you need a genetic counseling that I perceive from your family history, so that we can avoid delayed diagnosis. We can create opportunity for prevention, and we can help the family members to be identified whether they are at risk or not. And why this is relevant? Because even though percentage of the genetic cancers across the gynecological malignancies differs, like ovarian cancer has higher percent of inherited component, relatively less in cervical cancer, but overall still 10 to 20% of gynecological cancers are caused by the inherited mutations. And that's why it's very pertinent that we identify these risk flags in the clinic and take the necessary steps. So how can we really go about it? We are not going to really take a detailed family history like a genetic counselor, of course, but just few leading questions can really help us triage and identify a particular at-risk individual. And what could be these factors? There would be two components to the inherited disease history taking. One would be, of course, the personal history, and another would be the family history. So there would be certain risk factors which attribute or raise a flag of probable inherited cancer risk. That would be, and what has been the history of cancer in the family, how many first degree relatives or second degree relatives have been affected, what was their age at that they were diagnosed, because the inherited cancers usually are diagnosed at earlier age, and that serves as a very crucial indicator for us to dig deeper. And there are always patterns which can help us recognize which syndrome this particular family may be affected by, or may belong to the inherited cancer risk syndromes. So, like for example, as I said, ovarian cancer is a cancer which has almost 20% of the cases caused by inherited. So for ovarian cancer, any age diagnosis should lead the ovarian cancer diagnosis should lead us to really go dig deeper. For other cancers like the breast cancer or the endometrial cancer, relatively earlier diagnosis less than 50 years of age, if there is a family history of a triple negative breast cancer, if there is a family history of a male breast cancer, or if there has been a family member has been affected by multiple cancer, either synchronously, that there were two tumors diagnosed simultaneously, or there was earlier breast cancer and then she suffered from ovarian cancer. So these are the factors that we are really going to ask about when we are really trying to identify a particular individual who might be at higher risk of a particular carrier of a particular cancer syndrome. There are n number of cancer syndromes, and as a practicing gynecologist, you are not really required to know what are these syndromes, what are the genes involving, because the list is really endless. I have just captured 4 most common hereditary syndromes that can be relevant to gynecological malignancies, but there are many more. And That's why just trying to club together the cancers like, okay, ovary and breast together would be HBOC is not really the ideal way, because the BRCA1-2 genes or the HBOC syndrome can lead to multiple other cancers. There might be gastric cancer, there might be a case of prostate cancer in the family, or a pancreatic cancer. So really clubbing just by the organ system is not the ideal way. But definitely, if you see such patterns, definitely the risk becomes much higher of a particular hereditary syndrome being present. So just, and each syndrome will have different criteria when to suspect a particular syndrome. I have just listed for HBOC, like, which I already mentioned, that there are either multiple tumors belonging to the HBOC syndrome. There is a male breast cancer, or there are bilateral breast cancer in the same individual. Or so there are, for each syndrome there would be certain criteria. But again, we have to really focus on the major alerts, the age of diagnosis, more number of family members being affected, and multiple cancer histories in the same family. That should really so this is something like a particular HBOC syndrome may look in your clinic, that you are seeing a patient with a family history of mother suffering from ovarian cancer at earlier age, and either a sibling suffering from breast cancer. That of course would alert you about HBOC syndrome. But there might be different presentation. There might be a family history of ovarian cancer, colon cancer, and endometrial cancer. Now we really feel that, okay, these are so very different tumors, they really do not belong to a particular syndrome and may not be really inherited. That might be just a chance or sporadic chance that so many members were affected. But no, this particular picture can be present in Lynch syndrome, where you have colorectal malignancy risk, you have endometrial malignancy risk, and ovarian cancer, though uncommon, still can occur in even Lynch syndrome. So that slide is just to really highlight that don't get biased about a particular group of tumors occurring together in a particular syndrome. Just multiple cancers in first degree or second degree relatives, as well as early age at diagnosis, is what that can alert us. And again, when I say early age of diagnosis, there are exceptions to every situation. There will be cases where the cancer diagnosis is quite late, confusing us that, okay, it might be sporadic, that ovarian cancer occurring around 60, the colorectal cancer around post 50. But still, there might be certain, because every cancer syndrome has variable penetrance or manifestation, and thus the age risk at which a particular gene mutation may manifest may differ. And thus age alone or a grouping of certain cancer types alone cannot be the only criteria. They should serve as either of them being present should serve as a red flag and lead us to looking further or guiding the person further for counseling. So essentially, when we are talking about hereditary cancer screening, technology also is very relevant. Earlier we used to, and even now there are multiple clinicians who insist that, okay, it looks like HBOC syndrome, let's get BRCA1 and BRCA2 tested alone, because there has been a history of breast cancer and ovarian cancer, it has to be HBOC. But there are multiple genes which can really lead to HBOC syndrome like picture, like PALB2 gene may cause similar cancers. Not really limit or judge that, okay, these two mutations alone will be genes alone shall suffice. There are multiple genes which can be contributing for a hereditary cancer in a particular organ, and that's why broad NGS based panel are very necessary. And as well as there are certain types of alterations which are not detected by routine NGS, and that's why like deletion duplication analysis of BRCA is very relevant, because it leads to 3 to 5% of the inherited BRCA mutations. And these mutations are in a way detected by platforms like MLPA. So the
ವರುಣ
technology.
ಅದು ಓಪನ್ ಯಾಕೆ ಇಟ್ಟಿಲ್ಲಪ್ಪ ಇವತ್ತು ಕಷ್ಟ ಆಗತ್ತೆ.
Okay, so the technological advancements have to be paid attention to when we are selecting the panel or the laboratory where we send the sample. And why once so this is how a particular lab report is going to look, where we are going to any particular lab will report you which gene has been affected, what has been the variant, whether it's a heterozygous variant or only one copy of a gene is affected or both copies of the genes are affected, and what is kind of the inheritance pattern. And there would be further description about the risk assessment. And even when all such descriptions are there, it is always best for a positive when the positive report is seen, hereditary cancer screening report, a genetic counseling is absolutely mandatory, because then the anxiety associated with a positive report needs to be really the patient needs to be educated properly. At the same time, even after getting a positive reports, patient tend to really not action it, in the sense are not very vigilant with the screening. And that's why a detailed counseling should be advised with a genetic counselor. And majority of the labs who will be performing the genetic testing for hereditary mutation would have in-house counselors and that service will be of course free of charge for from all these laboratories like us when a positive report is given out. So definitely you have to guide the patient to avail these services. So each mutation, because why specialized counseling I am insisting, because each gene will have very varied risk. Even if it is BRCA1, the risk of a particular cancer type may be different. Like BRCA1 will have different risk for breast cancer. BRCA2 may have different risk percentage, and the age-wise risk association may also differ. And that's why detailed counseling is going to really customize a particular surveillance plan for that particular patient. And is this information just relevant in today's world for identifying the family your risk of a particular cancer with a positive family history? No, the expansion of the indication of use has been significant in past few years, wherein we have now interventions also recommended by guidelines based on the genes which are seen as positive. For example, RRSO may be recommended in of course it has to be with a proper discussion with the individual and the family, but there are various recommendation guidelines based recommendation for risk reduction surgeries based on the gene that is affected. And that's why the actionability is there to really reduce the risk of the cancer occurrence in a particular carrier who has not yet suffered from a corresponding cancer. And the utility goes beyond the risk reduction surgery. If at all there is an event of cancer in that particular individual, these gene mutations are now helping us even select the therapies for those particular individual. So just to summarize, genetic risk assessment does not end at just ordering a test. It is it begins much earlier by identifying a particular individual who should undergo testing. It also continues by choosing the right platform and the right test. It also involves interpreting the results correctly or getting the help in appropriate interpretation of the result. And when everything else is done, it has to end in proper action plan for the results. It is not necessary that every individual is going to choose for risk reduction surgery, but really communicating the results appropriately and helping the patient choose a particular option is something that should be a logical consequence to a genetic risk assessment. So with this, I will like to end my talk on hereditary screening here. Thank you so much for your patient listening.
Thank you, Dr. Darshana. I'm sure that all of us today, we know very well that in our busy gynecology practice, day-to-day practice, because gynecologists are those people wherein we keep seeing a spectrum of cases when it comes to obstetrics, again, gynecology, and again, in that, when it comes to cancers, many a time we may not be able to give that impetus or give that specified time to think about these things. I'm sure Dr. Darshana's talk today would have enlightened us in terms of which are at least the important cancers to ask, especially with history taking. And if in case they by themselves, if that is if they don't mention, if they mention, then definitely like what is it in line that we have to have in our mind, and like who are the ones that whom we can triage them, to what kind of gynecologic, I mean to say, genetic counseling. So, excellent talk, and thank you so much, Dr. Ashna, for the first talk. We will be waiting for your second one again. I'm sure there will be many questions. We would be very appreciative of anybody who could ask their questions via messages, the chats in the group, and we would love to answer them at the end of it. Our speakers would be more than happy to. So, yeah, Prerna, how about the next talk? You can
Yes,
take over, Prerna. Yeah.
yes, sir. Thank you, sir. Mr. Arun, can you please share the CV, one slide CV of the next speaker, please? Thank you, Mr. Arun. So let's move on to the next topic for today. The next topic is precision staging, how molecular profiles guide management in endometrial cancer. Our speaker is Dr. Kiran sir, who is Assistant Professor in the Department of Medical Oncology at JSS Hospital, Mysuru. Sir has a strong academic orientation, extensive experience in solid and hematological malignancies, and multidisciplinary care. He is actively involved in research and teaching activities. Over to sir for his topic.
Yeah. Good evening, everyone. I'm Dr. Kiran from Mysore. At the outset, I would like to thank Dr. Rupesh sir for giving me an opportunity to talk about this hot topic and today's CME. Shall I share my screen?
Please go ahead, Dr.
Yes.
Kiran. Yeah. Yeah. So before Dr. Kiran starts his talk, just one line I would like to say to all the gynecologists, to all the people who have logged in for today's meeting. See, all this while, endometrial cancer was just like a simple hysterectomy, and from there, and a BSO in menopausal women, or fertility sparing in certain groups, or sometimes just a lymph node dissection, or just paralytic in advanced. It used to be only like that, but there onwards, we have actually come into an era wherein the molecular subdivision of each of the endometrioid, the same endometrioid malignancies which we used to treat earlier, has actually taken so much of changes that many a times as gynecologists we ourselves are like we actually we find it so difficult. So that is the reason I wanted a medical oncologist of Dr. Kiran's caliber to actually be here and give us and enlighten us about the latest aspects. And yeah, as Dr. Prerna said, he's a highly academic person. And over to you, Dr. Kiran. Please enlighten us with your talk.
Thanks, sir. This is regarding the precision staging, because nowadays the whole endometrial management of the whole endometrial cancer has completely changed compared to, because earlier we used to see the management based on the 2019 FIGO staging, but nowadays it has completely changed. The whole thing between 2009 and 2023 FIGO staging is completely different. And now, so why precision staging is needed? Because it is very biologically heterogeneous disease, and what all these days we are using FIGO 2009, which was based on the grade of the disease, histology, and mainly LVSI. LVSI used to drive us about the further treatment options, basically for stage 1 and stage 2 tumors. And once this LVSI is negative or positive, the stage 1A or 1B, depending on the myometrial invasion, which tells us about the further treatment options, whether radiation has to be given or brachy has to be given. That was decided by all these factors. But now there is a whole change, because we have seen that some patients used to be over-treated and some patients used to be under-treated because of this previous staging. So they have incorporated this molecular profiling, which improves the risk stratification, which can guide us the further treatment options, where patients can have a proper treatment for that particular molecular subtype and can have a reduced recurrence rates in future. So that is what about the today's talk, and it's an extensive topic actually if we go in detail. But today I just like to brief you the about this further management. So a basic one slide about the epidemiology and clinical challenge. This is one of the most common gynecological malignancy in developed countries, and it predominantly affects the postmenopausal women. And also the it is mainly because in the increased rates of obesity, metabolic syndromes, and aging population in the developed countries. Even though early stage has a favorable outcomes, nowadays because of the incorporation of molecular profiles, even the early stage with few molecular subtypes will have a poor prognosis. So subtype, that subset behaves aggressively despite the early stage. This was the conventional risk stratification, that is FIGO 2009, which depends on the histological type and grade. Type means it can be either endometrioid tumors or clear cell or serous and other types, and depth of myometrial invasion, which defines the staging, that is stage 1A, 1B, and stage 2, and also LVSI. Earlier, we used to get some patients where we had they are mentioned as only LVSI present or absent. But nowadays it is still more useful. It is still more, we need to clarify that whether LVSI there are less than 5 vessels or more than 5 vessels. That is also important in the present FIGO staging system. So this was the thing. The previous classification 1A and 1B, I think you are well aware of, like tumor confined to the uterus, that is less than 50% of myometrial invasion, and 1B more than 50% of the myometrial invasion. And nowadays sometimes the tumor is still confined to the endometrium, that is not there in the previous classification, but in the new classification it is there. So stage 2 cervical stromal invasion, stage 3 once again which has gone beyond the endometrium, sorry, beyond the uterus, that is into the serosa or the adnexa, and or vaginal parametrial involvement. Once again, it is stage 3C. Not much changes between the 2009 and 2023 FIGO classification and stage 3 and stage 4. So it is pelvic node or a para-aortic node involvement, and stage 4A, it is infiltrating into the surrounding structures like bowel or bladder mucosa, and stage 4B is distant metastasis. What happened with the previous FIGO classification was there was inter-observer variability in grading, whether it can be like well differentiated sometimes, and when we review the slides, we got it as like grade 2, and sometimes LVSI was positive and sometimes LVSI is negative, because it was guiding the further adjuvant treatment. And hence many of the patients were getting either over or under treatment, and it was poor prediction of recurrence in some patients. So these were the limitations. But in 2023, the FIGO has updated its staging system. It mainly revised the early stages of endometrial tumors, that is stage 1 and stage 2, to include histological subtypes and also the tumor patterns. And it also incorporates the molecular-based results into consideration, especially in the definition of early stage disease. So molecular classification is the key point in FIGO 2023 classification. That is the molecular revolution, which TCG has reclassified endometrial tumors into 4 molecular subtypes, which has got a distinct prognosis and which has got implications in the terms of adjuvant treatment, and also it tells us about the recurrence rates. So these are the main 4 subgroups. So whenever a patient has been diagnosed as endometrium, before going in for treatment, adjuvant treatment, we need to look for, it's a mandatory that we look for these parameters like pole mutation and MSI and P53, or no specific mutation profile, that is copy number low, NSMP. So these are the 4 important molecular subgroups in CA endometrium. So P53 abnormality is seen in 15 to 20% of the cases, which is having a very poor prognosis. This is one subtype which has a very poor prognosis, in spite of being in, like, if a patient of C endometrium diagnosed as stage 1A in the previous 2009 FIGO staging system, if at all, if she is diagnosed as like P53 abnormality, then automatically the stage switched over to stage 2C. That will come to in the next slide. So P53 abnormality is having a very poor prognosis, which is detected by either IHC staining or by sequencing. And majority of these patients do need adjuvant treatment either by CTRT, that is chemoradiotherapy, or chemotherapy and radiation as a sequential treatment. So MMR deficiency once again is seen in 15-25% of the patients. Subtype with an intermediate prognosis, which is mainly detected by IHC staging and MSI analysis by PCR or by NGS. And these patients do require some radiation. Along with that, these patients have a wonderful response for immunotherapy. The third thing is the pole mutation. This is 7 to 9%, which is one molecular subtype which is having a very good prognosis. In spite of being stage 2, if patient detect pole mutation, they will consider as stage 1. So this subtype will be detected by NGS or Sanger sequencing. Hence, early stage tumors which are pole mutant do not need any adjuvant treatment because this behaves very well and there are very less chances of recurrence. The fourth subtype is without any specific molecular profile, that is no specific molecular profile NSMP, which is seen in majority of the patients, that is 50 to 55%, which is having absence of any other abnormalities. And these patients, depending on the stage, requires the further treatment. Now coming to the first one, that is pole ultra-mutated tumors, which has got an excellent prognosis, have a very high mutation burden. Pole ultra-mutated tumors, the stage should be recorded as stage 1A, mutated pole mutant. This is the new one, stage 1A, mutated pole mutant, regardless of the LVSI or histological type. Irrespective of the histological type, whether it is like other histological subtypes with a poor prognosis, like clear cell endometrioid or other serous tumors, irrespective of that, if pole mutation is positive, they should be considered as stage 1A. So there is a potential for treatment de-escalation, including surgery and adjuvant treatment in these patients. Next, MMRD, which has got intermediate prognosis. This is associated with Lynch syndrome. And this group of patients respond very well to immunotherapy. We have now almost 3 to 4 immunotherapy drugs which are available, and addition of immunotherapy to chemotherapy in adjuvant setting will be considered as a new gold standard of treatment based on different trials, and these patients will have lesser recurrence rate and prolonged relapse survival by combining immunotherapy to chemotherapy in adjuvant setting. Of course, this standard chemotherapy of choice is paclitaxel plus carboplatin. And the last subset of patients, that is NSMP, copy number low, it represents 50%. Here, these patients, sometimes they have estrogen receptor positivity, which was very significant in this subgroup of patients, which has got intermediate risk. And these patients can be treated with hormonal treatment. Even CDK4 inhibitors has been tried in these patients. So this has got an heterogeneous outcomes. Now the P53 abnormality, which is having a very poor prognosis, these patients often have a serous histology, and irrespective of the stage, these patients require aggressive adjuvant therapy because of high chances of recurrences. So tumors with TP53 mutations confined to the uterus, even though if it is confined to the uterus, with any degree of myometrial invasion, if the patient is having only endometrial involvement without myometrium, those patients can be skipped. Apart from that, any degree of myometrial invasion, either less than 50% or more than 50%, these patients should be classified as stage 2C, that is stage 2 mutated P53 abnormality. Regardless of the LVA status, regardless of the histological subtype, regardless of cervical extension, and regardless of myometrial invasion. So once P53 is positive, these patients should be treated aggressively with chemotherapy and also radiation. This is the PORTEC-3 trial, where the addition of adjuvant chemotherapy during and after radiotherapy for high-risk endometrial tumors showed that it did not significantly improve the 5-year OS, but it did enhance the RFS compared to radiotherapy alone. Means this is for all patients. But there was a subgroup analysis which considered that TP53 mutated tumors had a significantly better outcomes when chemotherapy was combined with pelvic radiation. So this was PORTEC-3 trial. Now PORTEC-4 is the first clinical trial that is also there. It has included newer molecular subtypes and guiding the treatment to avoid both over treatment and under treatment in depending on the molecular subgroup population. So the current clinical practice suggests that standard adjuvant care for locally advanced P53 abnormal endometrial cancers should be a combination of chemotherapy and radiation, both. So all this ESGO, ESTRO, ESP risk stratification has integrated this molecular subtype with clinical pathological factors. There are 4 groups defined as low, intermediate, high intermediate, and high risk groups. This is shows the risk groups where pole mutant groups, whether it is stage 1 or stage 2, it is comes under low risk. MMR deficient stage 1A comes under low risk, but P53 abnormality stage 1 without myometrial invasion, that means only with endometrial involvement, comes as intermediate risk. Apart from that, with any degree of myometrial invasion, stage 1 to stage 4A all comes to high risk group. And intermediate risk group, once again, we have MMR deficient and non-specific molecular profile, where stage 1B and stage 1A, and high intermediate risk, once again, stage 1A MMR deficient group. And high risk group, apart from P53, we have stage 3 to stage 4A endometrioid and other histological profiles like serous mixed undifferentiated carcinosarcoma with myometrial invasion with no residual disease. Advanced or metastatic disease has got a high risk disease. So this is the newer molecular classification. This is the gist of newer molecular profile, which has been incorporated to decide the treatment. Stage 1A, which was there earlier, like less than 50% myometrial invasion, has been subclassified into A1, A2, and A3, where A1 is non-aggressive histologies, which is limited to only endometrium, that is endometrioid tumors. Stage 1A2 means non-aggressive histologies, that is endometrial carcinoma, which involves less than 50% of the myometrial invasion with no or focal LVSI. Earlier, this LVSI, which was there, that was there as stage 1 or stage 1A or 1B. But LVSI, when it's present, significant LVSI, when it comes to more than 5, it has been shifted to stage 2. So here stage 1, A1, A2, and A3. So A3 means when there is involvement of the ovary with intact capsule, then it is stage 1A3. So depending on this, stage A1 doesn't need any molecular profile whenever the tumor is limited only to the endometrium with non-aggressive histologies. It will be considered as only a good risk disease with observation is enough. So stage 1, A2, whenever there is a myometrial involvement, then we need molecular classification like pole mutation. Whenever pole mutation is there, then it automatically becomes stage 1A mutant pole. So these set of patients, irrespective of cervical stromal extension or irrespective of the LVSI or histologies, only observation is enough. No adjuvant treatment is needed. So P53 abnormality, then once again, the stage automatically upgrade to from 1A2 or 1A3 to 2C. And non-specific mutation only, once again, if there is no P53, no pole mutation, and no MMR, then observation is enough. When it comes to 1B, more than 50% of the myometrial invasion, then once again, pole mutation, observation, P53, adjuvant treatment is needed. Non-pole, if the age is less than 60 years, then observation. Age more than 60 years, patient need brachytherapy, no systemic treatment. And stage 1C means aggressive histologies, which is limited to endometrium, all types, only observation is needed. So whenever a tumor which is limited only to the endometrium, irrespective of the histologies, observation is enough. This is FIGO stage 1. Now this is FIGO stage 2. Here we know stage 2A means cervical stromal invasion. Once again, the molecular profile, pole, observation, P53, systemic treatment and radiation, and other subtypes only radiation. So once again, like stage 2B means here substantial LVSI. What do you mean by substantial LVSI? It means if the LVSI is seen in more than 5 vessels, it is called as substantial LVSI. So pole mutation, once again observation, deficient MMR, only EBRT is enough, or sometimes depending on the stage, we can go for a combination of chemotherapy and addition of immunotherapy can also be done, that is ICI, EBRT plus ICI, immunotherapy. P53 abnormality, it becomes stage 2C, then chemotherapy is needed. So stage 2C, aggressive histologies with any amount of myometal invasion. So that is, once again, pole mutation is there. It is having a good prognosis, only observation. P53 abnormality, adjuvant chemotherapy with radiation is needed. And other types, once again, radiation plus chemotherapy. And when there is a deficient MMR, then chemotherapy plus immunotherapy is also required. Once again, there is not much changes in stage 3 and stage 4. In stage 3, pole mutation is there, then definitely patient needs EBRT or observation if though no residual tumor is there. So not much changes in stage 3 and stage 4 between 2023 and 2009 FIGO classification and also in the management. We have seen in studies like some P53 abnormal patients behave like DNA repair mechanism deficient. So if these patients are HR deficient, then there are trials which have shown that addition of olaparib, that is PARP inhibitors, olaparib for adjuvant 2 years of maintenance olaparib has shown some improvement in the PFS. So this molecular staging also has an impact on the surgical staging, which guides the extent of lymph node dissection, and it can avoid over-treatment in pole mutant tumors. So once again, as we discussed in the last slide, like adjuvant therapy, it has a great impact where pole mutant tumors we can consider only observation or minimal therapy, only radiation. P53 abnormality need to give chemotherapy with radiation and MMRD. There is always there is an emerging role for immunotherapy like pembrolizumab, dostarlimab, and atezolizumab. And advanced and recurrent disease, once again, if there is MMR deficiency or MSI high tumors, immune checkpoint inhibitors has always a role. P53 abnormality, chemotherapy-based approaches is the standard of care. And there are ongoing trials with other target therapies like PARP inhibitors can be tried. And in NSMP tumors, if ER positive or PR positive, then we can go for CDK4 inhibitors or some hormonal treatment can be tried in these patients. The future directions are with integration of this molecular and imaging biomarkers can be used, and circulating tumor DNA for surveillance can be used just like in breast cancer and colon cancer. It is already there. And personalized adjuvant trials has to be done depending on this molecular profile, either to escalate or de-escalate the treatment. So take-home messages, molecular profiling is now essential in endometrial cancer, which guides us the further treatment, adjuvant treatment options. Precision staging improves the prognostication and hence help us to decide the treatment and also tells about the prognosis of the disease. It guides the tailored surgical and adjuvant therapy. Thank you.
Thank you, Dr. Kiran. That was truly an elaborate and an exhaustive information. I'm sure that you have not just targeted the gynecologists to know about the current changes in the classification and the impact of doing the genetic testing like pole testing, pole mutation, or even P53 and MSI testing. So it's not just that, but also with regards to the impact it can have for the recurrences as well as the upcoming trials. So it was a fabulous talk. Thank you so much for your time and your discretion. I would just like to say one thing about for especially for the gynecologists. I'm sure that all of you now have been hearing of late that if I have to say over the last 10 years, maybe the gynecologists specifically, um, because my journey as a GYN oncologist from the last 15 years, I have been seeing the evolution that has taken in place in endometrial cancer. Initially, it was like, only THBSO used to be done many years ago if it's a low-grade tumor. And later onwards, the importance of MRI came. Later onwards, the importance of doing a complete systematic pelvic and para-aortic lymph node dissection came. Later onwards, the concept of SLN came. so which is quite happening in today's world. And later onwards, the importance of MIS, the minimal invasive surgery for endometrial cancer, came. And later onwards, the importance of the non-endometrioid histologies and how we have to be quite, aggressive about thinking about them, not just do a simple hysterectomy, for such cases. And now comes the molecular understanding of endometrial. As Dr. Kiran aptly said, that the behavior, the understanding is so heterogeneous that the molecular subtypes have definitely aided. But mind you, there's one more thing that there's been a lot of confusion also that has been added, especially with regards to, the subtyping has become so much in depth that uh, of course, most of the times the adjuvant treatment wouldn't change grossly, but there are these isolated cases. For example, recently I had a case wherein the pole was non-mutant, MSI, I mean, MMR was proficient, and P53 was abnormal, but she was ER negative, an endometrioid histology. So I just got to know that these are also the patients who may require chemotherapy. So, like this, definitely it has helped, and I'm sure that we will get wonderful data in the coming years after these molecular subclassifications. And as we start to do this as a standard of practice, the future years will tell us how significant. I'm sure already we have trials supporting the current evidence for testing, but we will definitely have much better data from our own setup. And also for the gynecologists, especially since the genetic labs may not be as avidly available, in all places. I would sincerely request each one of you to always loop your GYN oncologist, even for a virtually also, like before the surgery as well as after the surgery. It's always wise. Especially, I know that many of us in the group, especially many of them who are joined, like many Dr. Prabha Desai, and there are many people in our group in Karnataka who do fabulous laparoscopic surgeries. So it's very imperative that even before surgery and after surgery, especially after the histopathology, it's always wise to loop in your GYN oncologist at one of at more both these junctures, so that it will help a lot to guide you to further go to the med onc only or the radiation oncologist only or both. So this is something which everybody of us have to know. Thanks. It was an excellent talk, Dr. Kiran. Thank you so much.
Thank you. Thank you.
Uh, Dr. Prerna, over to you.
Thank you, sir. Mr. Arun, can we have the CVs, please? Thank you. So coming to the final session for today, topic being beyond
It's my
surgery and chemotherapy, why genetics is now vital to the comprehensive management of ovarian cancer. This topic will be jointly handled by Dr. Darshana ma'am and Dr. Rupesh sir. I've already introduced Darshana ma'am. So coming to Dr. Rupesh sir, we are familiar with sir's achievements and his clinical expertise. So one thing I want to add is that sir has reinvented himself as an innovator by inventing a novel device for cervical cancer detection, the world's first AI-powered speculum called VisiSpec. So that is one thing I want to add to sir's introduction. Congratulations, sir, on your achievement. Over to sir and ma'am for the session. Thank you.
Thank you so much, Prerna. So yeah, as most of us, most of the Kasoga is familiar with me. Thank you so much. Coming to the third part, as Dr. Darshana in her initial talk clearly said, that her first part of the talk will be mainly the germline aspect. And the second thing, the next part of the talk will be the somatic mutations, wherein, uh, as all of us already have today known, that those mutations which are transferred from one generation to the other are germline mutations. In a very layman's terminology, I'm speaking because I'm not as good as Dr. Darshana. So, somatic is obviously that acquired mutation because of which the tumor has taken place. So we are speaking about that, the relevance of that in today's world for ovarian cancer. I'm actually not sharing any screen or any slides. I would just like to have an initial briefing up for the talk that Dr. Darshana would say. As all of us know, that ovarian cancer uh, has been one of it's called as a silent killer, and especially the serous variant. So we all know the classification, the epithelial tumors, germ cell tumors, the sex carcinoma tumors, and the others. So just in this many classifications itself, You will be amused of the number of ovarian cancer cases that I see every year. I mean, it's increasing day by day, especially the serous ovarian cancer, because these are the ones which present in advanced stages. They usually, as all of us know, in our initial textbook description of type 1, type 2. So, yeah, more than that, let us know that the fimbrial end is the site where actually the serous tubal intraepithelial carcinoma, the stick starts, and from there that goes on to the ovarian surface, and with repeated ovulation, the multiple ovulation theory, the cells get deployed there, and from there is the ovarian cancer starts. So this is all what we know. This is the classical high grade serous tumors, the type 2, whatever. The type 1 are the low grade serous tumors. Of course, we don't clearly say the type 1, type 2. Mainly, we have to categorize into high grade or low grade serous. So low grade serous is something again a little tricky most of the times because it is chemo resistant. Whereas high grade tumors, serous tumors are pretty chemosensitive, at least more than 90% of them. But low grade serous are almost always, most of them are chemo naive. They do not respond to chemotherapy. And these are the ones which usually develop from a borderline tumor, a serous borderline tumor going and getting transformed into an invasive implant and a low-grade serous carcinoma. So low-grade serous carcinoma, the precursor is a borderline ovarian tumor. So we have to be very, very cautious of borderline ovarian tumors also, especially because they are seen in the younger population. And in this group, especially if a suboptimal surgery is done, then it can lead to catastrophes. So recently, I had a very young lady, in whom the frozen was borderline tumor, but unfortunately, the final histopath was low-grade serous. So that was a very tricky situation. Luckily, it was confined to one ovary, and still I have been able to perform a fertility-sparing surgery. So the implications are huge. So we will need to have a thorough understanding of the histology. So whenever you do a surgery, especially an early ovarian cancer surgery and suspected ovarian cancer, especially after mild elevation of the tumor markers and MRI showing diffusion restriction area of solid and cystic areas, and then we are doing MRI suggesting diffusion restriction and low ADC values. We've had a webinar last time about this. And yeah, we do a surgery, you send it to frozen section. So always ensure that a surgery is the cornerstone for treatment of ovarian cancer. Any time, any cancer generally, especially ovarian cancer, the surgery forms the biggest cornerstone because that has been proven as the single most important predictor in survival from various years. Whatever studies have been done, that has been proven to be shown as a single most powerful predictor of survival as optimal surgery. So optimal surgery carries extreme importance. So in today's era, of course, we all know about the importance of optimal surgery. Like earlier days, we were like leaving behind some disease also was considered as normal, but now leaving behind no disease is considered as normal. So CC0, or a completeness of cytoreduction score of 0, wherein we don't leave behind any disease, or max less than 2.5 millimeters of disease, is something called as optimal. We all know about it. And of course, in advanced stage, whenever beyond 1C1 and or any high grade, even 1A also, if it's high grade histology, we have to give chemotherapy. So that is a combined decision taken by the Gyne oncologist and the medical oncologist. Yeah, this is all there, but we all know about all these things. But I'm sure all of you would be amused if I say that in today's practice, especially my practice, has so significantly changed considerably that almost every single case of ovarian high-grade serous tumor, every single case goes for a HRD testing. So HRD is homologous recombinant deficiency testing. So we have the HRR pathway by which the genes get repaired. So if that HRR pathway is abnormal, I'm sure Dr. Darshana will be telling more in detail about those things. So that is when we have all these PARP inhibitors, what Dr. Kiran was telling for the BRCA mutations or the HRD abnormalities. So we use something called as PARP inhibitor. I'm sure all of you would have heard about olaparib, which is a game-changing drug. So now therapeutically, we earlier used to speak of 5-year survival for ovarian cancer. So ovarian cancer has been one beautiful cancer in terms of every single thing, has been which has been in use for ovarian cancer, has been showing positive survival, positive trend towards survival, be it intraperitoneal chemotherapy, be it HIPEC, be it optimal cytoreduction, be it the doublet of carboplatin paclitaxel, be it addition of bevacizumab, of course, in certain subsets, be it olaparib, be it HIPEC. So multiple things have added to the survival. Of course, the cost of treatment has definitely gone up. So we try to bring it down as much as possible. And nowadays, we also have labs who are very quite very understanding, especially in the costs also have come down. So definitely, I would like to say that, in fact, the recent paper that I presented in Berlin last September in the European Society of Medical Oncologists. So it was a very special conference to me because I was the surgeon presenting on in the medical oncologist conference, but it was very insightful to me because we had a pooled data, Indian data of about 290 cases of ovarian cancer, which we presented, and wherein the importance of molecular typing, it leads us to newer insights. We get to know about the survivals. In fact, my own patients, when I see are surviving, are having better recurrence-free survivals than those patients whom I used to treat 5 years ago when these modalities were not available. So definitely, I find it very, very important that all of us know about the molecular aspects, the genetics, as the genomics or whatever it is, in ovarian cancer as per se, apart from endometrial cancer, beyond surgery and beyond chemotherapy, because we all of us know about the importance of those things. So yeah, over to you, Dr. Darshana, because this is one thing what all of us, I'm sure, all of us know, but I won't. I mean, I'll be very happy that all of us learned today from you, the expert, about the importance of all these terminologies like HRD, HRR, the PARP inhibitors, and all these stuff. So over to you, Dr. Darshana.
Yes, thank you, sir. So, in consideration of time, I will try to be quite concise when we talk about this precision oncology. So, whenever we are talking about personalized medicine or precision oncology, it means that we identify the changes which are unique to that particular individual and treat accordingly. And whether it is, and today's topic would be alluding to how it is really changing the management of ovarian cancer. So yes, we were initially just focused on the histopathological classification, but similar to endometrial cancer, even though not to that significant extent in prognostication, still ovarian cancer also has evolved with multiple targets being identified. And for any solid tumor or any cancer now, one size does not fit all. It has to be a personalized treatment that has to be undertaken, because the reason is that not about the diagnostic evolution that has happened in terms of molecular testing, mainly the options that we have in the clinic today in terms of personalized therapies, targeted therapies, or immune checkpoint inhibitors, and the latest addition being ADCs, antibody drug conjugates. It has become absolutely mandatory, and all these new drugs, if we see, are majority of the drugs now in oncology which are being approved since past 5 years, there is always a companion biomarker which you need to test to select your patient for that particular drug. So yes, there is so much more to really offer to our patients if we look comprehensively, or if we look in all possible directions, and not that just treat every ovarian cancer patient just based on the histopathology, but identify the nuances and identify the targets which can give them better recurrence free survivals, and hence maybe preferably a better overall survival as well. So why does it matter? Because as I mentioned already, it is not organ specific differentiation alone. These diseases which are like two serious ovarian carcinomas may be different at molecular level, and they would be different. Same histology does not mean same at molecular biology, and thus does not mean same drug responses. And thus we have to identify the right therapy for our patient that is going to give us improved response rate, at the same time maybe manage the toxicities of unwarranted or the drugs which are not anyway going to act, and thus save them from the toxicities. So, with all these evolutions happening in the systemic as well as the localized therapies that we have to offer to our cancer patients, currently, when it comes to precision oncology, the molecularly targeted therapies and immune checkpoint inhibitor is where the evolution of precision oncology has been happening at a very fast pace. And now we have so many gene alterations, so many different kind of genes which are becoming relevant. The lung at one time was the poster boy of the precision oncology, wherein we had so many targets available. But now the other cancers, such as even ovarian cancer, are now catching up because there are so many organ agnostic approvals which have happened. So just for what is organ agnostic approval? That means FDA approves a particular drug irrespective of the cancer of organ of origin. So essentially, for example, there is approval of NTRK targeted therapies, which if a particular tumor, whether it is a sarcoma, whether it is a ovarian malignancy, whether it is a breast, if on molecular testing you see NTRK fusions, then yes, that patient is eligible for NTRK therapy and is going to benefit from it. And these organ agnostic approvals, which are of course relevant to ovarian malignancy as well, because they are not dependent whether it is ovarian or other non-ovarian organ of origin. And this spectrum of organ agnostic approvals has been increasing. Now we have the tumor mutation burden, which is kind of how many mutations are there in the tumor genome. Total mutation, higher the number of mutations, better the response with immune checkpoint inhibitors. The approval of TMB as organ agnostic approval. There is approval of HER2 amplification. HER2 was always associated in our mind with breast cancer, with latest addition of colorectal or gastric, but now it has organ agnostic approval for trastuzumab. If you have HER2 amplification in any solid tumor, that individual becomes eligible. So these organ agnostic approvals have opened doors for the ovarian malignancies in terms of high TMB, HER2 amplification, presence of RET gene alterations, presence of NTRK gene alterations. There are BRAF alterations if present, and which are, of course, BRAF is so common in the low-grade ovarian cancers, but presence of BRAF alteration in an aggressive situation would help you open up doors for the anti-BRAF therapy even in ovarian cancer cases. Thus, the molecular testing, the analysis of these findings in the individual's tumor has become absolutely mandatory, so that we can customize, we can personalize the therapies. And these testings, even though commonly done on the tissues, there is immense role, as earlier talk alluded to, role of liquid biopsy in really monitoring or even prognosticating our early stage cancer patients. So as I mentioned, no drug approval since past few years is without a companion biomarker, and that is why we have to really not, sorry, I'm sharing the screen still, right?
Yes, ma'am.
You're sharing, but it's
Yeah,
not
okay, sorry.
moving.
Yeah, sorry. Yeah. Okay, yeah, okay. So that's why molecular testing has become absolutely relevant, and these are the various drugs which are organ agnostic with organ agnostic approval that we are now available for our ovarian cancer patient. And I will, of course, definitely the most important aspect of molecular testing in ovarian cancer, as Dr. Rupesh already referred to, is the HRD testing, and we will definitely talk about it in a certain level of detail. But before that, I also want to highlight the role of liquid biopsy. Liquid biopsy, as you might be already aware, is nothing but doing the molecular profiling that we otherwise do on tissue sample from a blood sample. And essentially, not only blood sample, it might be any body fluid. It might be your ascitic fluid in ovarian cancer patients. And we have some interesting data on that as well. I will discuss about that. And how does liquid biopsy help us? It helps us to really identifying these targets, not all, but majority of these targets from a blood sample when we do not have access to tissue. There is a relapse where, because of comorbidities, we are not able to access, or if we have really done the molecular profiling, now we want to monitor our patients more sensitively, more effectively, so we can supplement our routine imaging with a liquid biopsy, like the molecular residual disease monitoring or the conventional liquid biopsy, wherein the cell-free DNA profiling from a blood sample or any body fluid can really help us to identify these various targets. And we can monitor the trend of these mutations in the peripheral blood. And with therapy being efficacious, the mutation trend has to really go downwards and eventually become zero. That would be the ideal situation. Now, coming to the most important aspect of molecular testing in ovarian cancer, which is nothing but the HRD, the homologous recombination deficiency. So, as the cells are continuously proliferating, there are always mutations which happen with every cell division. The difference is there are multiple repair pathways which are there, which will make sure that these mutations are either corrected, and if they are not corrected, that particular cell has to undergo apoptotic cell death. That is how we are saved, even with so many cells proliferation or cell divisions happening in our body since our birth. Still the cancer does not occur. But when does the cancer occur? When these repair mechanisms in certain way are impacted or are have become ineffective, and thus the cell is not able to correct these defects in the new cell that is formed, and thus the cell acquires the property to proliferate and eventually turn cancerous. And amongst these repair pathways, there are multiple, like mismatch repair pathways there. And if you have deficiency, as we see commonly seen endometrial cancer, if you have deficiency, then those patients are going to do exceedingly well with immune checkpoint inhibitor. But one of those pathways of repair is the homologous recombination, homologous recombination repair pathway. We otherwise refer to it as HRR pathway, wherein the corrections are done if there is a defect with double strand breaks happening in the cells. And when this HRR pathway is defective, then the cells accumulate these double strand breaks, and thus the cancer occurs, or thus the cancer may be more susceptible to the treatment with PARP inhibitors, which are going to really help in conversion of these double stranded breaks and going to initiate the cell death in the cells with these repair defects. Now, and thus we have multiple PARP inhibitors now available to treat our patient, olaparib, drugaparib. There are multiple such options which are available, which can be utilized for treating our HRD deficient cancer patient. Now, whenever the HRD score is being calculated, there are multiple ways and multiple thresholds have been set. Like with the Myriad platform, the threshold of 42 is there. With our platform or the foundation platform, the HRD positivity score of 16%. How do we derive these scores? These scores are derived by multiple analysis and that's why, because there are multiple types of alteration that we have to analyze in the lab to really derive the HRD score. So HRD costing or HRD testing cost are relatively higher compared to BRCA, but still with recent reduction in the sequencing cost, they have become much cost effective. And these HRD scores are commonly elevated, or HRD positivity is there in tumors which have BRCA1 or 2 mutation. If you have germline BRCA1 or 2 mutation, the HRD score is obviously going to be commonly positive. In of course, there would be situation where BRCA germline mutations also may not lead to high HRD score, but those are not the common situations. So somatic BRCA mutation or the HRR pathway mutations other than BRCA1 or BRCA2, like the earlier I have mentioned, like the ATM, the PALB2, or the other HRR like FANCA complexes, these are also going to impact. So even though you have tested BRCA, it is negative, you have tested it in germline, or you have also tested it on tissue to rule out somatic BRCA, there might be other mutations which can impact this pathway, leading to high HRD score and thus making the patient eligible for the PARP inhibitor therapy. And thus it is very important to not just test for the HRR gene mutations either on tissue or liquid, but it is very, very pertinent to get a HRD score profiling done to really identify more patients who can be eligible and can benefit from the ovarian cancer. And prospective clinical trials have established that even though HRD score is high, even if HRD score is high in absence of the HRR gene mutation, still the patient is going to derive benefit from the PARP inhibitor therapy. This slide again highlights that it is not only the BRCA gene complexes, there are multiple other gene mutations which are again going to contribute to the PARP inhibitor therapy. Another important aspect that I will like to briefly refer to would be the reversion mutations in BRCA. So whenever there is a HRD score positivity due to
Dr. Darshana, are you there?
I'm so sorry, I'm not sure when I dropped out.
Yeah, you
Am
were
I
speaking
audible
about the
now?
HRD, yeah,
Yeah.
the reversal.
Yeah. Okay. I will just start the screen share again. Okay, so there might be a second site mutation which may happen very close to the original germline mutation, and this second mutation, the what we refer to as reversion mutation, is a somatically or acquired mutation due to the PARP inhibitor therapies, which will restore the BRCA again, and thus the patient may no longer respond to the PARP inhibitor therapy. So these are certain nuances. So usually we see two BRCA mutations, we feel okay, oh, that's great, the patient is going to respond better. But if that situation has happened post PARP inhibitor therapy and those mutations are in particular vicinity, a lab will able to really guide you on that, whether that is really contributing to the acquired resistance to PARP inhibitors, and these are called as BRCA reversion mutations. So this is mainly to really refer to the HRD testing. But as I mentioned earlier, there are multiple other biomarkers which have led to the personal opportunities for personalization in ovarian cancer, and one of that being the MMR or microsatellite instability high status, wherein ovarian cancer patients, if they have deficient MMR function or they have microsatellite instability high, they are going to do exceedingly well on immune checkpoint inhibitor. And when you see such microsatellite instability high status on tumor tissue, it is of course imperative that we have to rule out the germline Lynch syndrome, or to confirm that it is somatic, not a germline status. So essentially to conclude, essentially to conclude the talk, there are so many opportunities in which are offered by the comprehensive genomic profiling in ovarian cancer that we have now, and there are multiple now prospective studies or even retrospective data analysis which have proven that this approach of personalization really leads to better advantages. So I think with that, I will just will be in 2 minutes focusing on the minimal residual disease component. This is nothing but a liquid biopsy profiling which is done on a blood sample, especially in patients who have undergone a curative intent surgeries, and either we are debating the role of adjuvant in certain nuanced subgroups, or we want to establish the recurrence risk. Then the MRD profiling from the peripheral blood has shown benefit and is a much better approach than the CA-125 to really monitor our cancer patient. At our laboratory, we have a very a great approach by combination of tumor informed and tumor agnostic MRD approaches, wherein essentially to say that the MRD testing becomes more sensitive by doing it on dual platform. And this is something that you can really utilize for your patients. And this is my last slide now. Just want to highlight, because it is not a common knowledge, that liquid biopsy can be performed on the body fluids as well. We have had the highest capture rate with especially ovarian cancer and ascitic fluid utilization, wherein when we profiled the ascitic fluid, the cell cytology was also negative for malignancy, but the cell-free DNA analysis from ascitic fluid confirm the involvement of the malignancy in the ascitic fluid, and that is something can of course change the staging of the patient and thus the further management. And that's why liquid biopsy, not only from the blood but even from the body fluid such as ascitic fluid, is very relevant. And with that, I think I will really stop here, and will be more than happy to answer questions if you have any.
That was just an exhaustive information for all of us, Dr. Darshana, and it was like as I told in my initial aspects, where we were just looking at surgery and chemotherapy, and now with the available molecular therapies, the precision oncology, the available information is something which is humongous for us to decide on how to go further. Thank you so much for that. Wonderful and exhaustive information. Thank you so much, Dr. Prerna. Dr. Prerna, are you there?
Yes, sir.
Yeah.
Thank you, sir. Thank you, sir and ma'am, for this final session. For me personally, the information on liquid biopsies, the follow-up with the blood samples, cell-free DNA, as well as of HRD testing was extremely informative. So I hope that the audience also takes a few lessons from today's webinar. So questions, there are 3 more questions in the chat box. Yeah.
More than the questions,
so I hope all the questions have been answered.
Yeah,
so
they have been already
as we
answered.
draw to the close. Yeah, they've already been answered. So as we draw to this session's end, so I have the task of delivering the vote of thanks. First and foremost, deepest gratitude to our patrons, Dr. Hiremat sir and Dr. Nagraj sir, and our president, Dr. Durga Das sir, for the unwavering patronage and for providing us with this platform to grow academically. Special thank you to our Secretary General, Dr. Shobha ma'am, and our Treasurer, Dr. Shobha Pembalgi ma'am. Your logistical and moral support is what turns these concepts into reality. And apologies for the late information. And thank you for still attending the webinar and supporting us last minute, ma'am. We'll make sure that this will not happen again. So, to our esteemed speakers, Dr. Darshana ma'am, Dr. Kiran sir, and Dr. Rupesh sir, thank you for decoding the complexities of genetics. You have truly turned a complex must-know into a confident can-do for all of us. The clarity that you've provided today will reflect in our clinical decisions and patient outcomes as well. We also thank Mr. Arun for his technical support and a seamless virtual experience. So finally, to all our audience who have been very active in participating and posting their questions and doubts in the chat box, I hope today's session will shed light on how to take decisions in the patient department as well as how to follow up. Thank you one and all. And on behalf of Kasoga Preventive Oncology and Gynecology Committee, I wish you all a very wonderful evening.